Hi everyone, thanks for being here. My name is Dave Rosen. I'm a colorectal surgeon at the Cleveland Clinic, and we're going to be talking today about colorectal cancer surgical principles. We completed another lecture already on the diagnosis and staging of colorectal cancer, so be sure to check that out if you haven't already, because that sort of ties in and leads up to this lecture here. So we'll go right into it. In terms of your preoperative evaluation for a patient that you're considering for surgery for colon or rectal cancer, you want to make sure you do a complete history and physical, make sure that they're an appropriate surgical candidate. And as we talked about in the previous lecture, you need to complete your staging workup, give any neoadjuvant therapy as needed depending on the staging and the location of the cancer. And what's also important is you want to make sure you have a complete colonoscopy performed for any synchronous lesions if possible, if it's not an endoscopically obstructing lesion. And even if it is endoscopically obstructing, sometimes you can get a CT colonography to give you an idea, because it's a shame to perform a major surgery and then you have a postoperative colonoscopy that shows a synchronous lesion, and then you have to do another surgical intervention that you could have taken care of at the same time for the patient. And lastly, it's really important to have good localization of the tumor prior to surgery. During colonoscopy, it's often very difficult to tell where you are as the landmarks aren't perfect. So unless you're in the cecum and you can see very clearly the ileocecal valve and the appendiceal orifice, or very distal in the rectum where you can see the clear rectal valves, anywhere in between there, it's more difficult. And some studies have shown as high as 15% time people being incorrect. So last thing you want to do is remove the wrong or incorrect part of the colon and miss the tumor. So a tattoo is very helpful. You want to make sure you do it in 3 quadrants. So that way, if one of those is in the mesenteric side of the bowel, you still will be able to see it on the anti-mesenteric side, which is much easier to see than the mesenteric side, where the tattoo could be obscured by the mesentery. All right, so let's talk about colon cancer to start, and then we'll move into rectal cancer later on in the lecture. So in terms of the extent of resection, what are our margins? How much of this colon should we take? Because obviously you're walking a balance between wanting to completely clear the cancer itself, but also you want to leave the patient with as much residual colon as possible, because that will help with their bowel function as they recover. You can think of the colon as a giant sponge, right? The biggest thing the colon does is absorb water. So if you have less colon, then you have less sponge ability and less water absorbed, and then the stools will be more runny, more frequent. Very generally, very frequently, the body can adjust to that somewhat, but you want to try to leave the patient as much colon as possible, but still giving them a good curative oncologic surgery. So colon and rectal cancers, they grow circumferentially around the lumen. They can extend out radially, but also longitudinally along the bowel, though that direction is a little less common. So because of this, we want to give these patients a 5-centimeter margin in general, proximal and distal. And the reason for that is not only because the colon cancer itself could grow longitudinally, but also the lymphatic drainage can be longitudinal itself or aberrant. So because of that, you want to make sure that you are getting a good margin, really clearing all those lymph nodes that might be passing cancer cells longitudinally, and clear that cancer for the patient. Another important principle of colon cancer surgery is a high vessel ligation. So the lymph node drainage of the colon typically runs with the vessels. And so we know that there's an improved survival with high ligation because you are clearing more of those lymph nodes. So the higher you go on the vessel, meaning more to the origin of the vessel or closer to the major vessel it's coming from, which is in colon cancer, either the aorta or the superior mesenteric artery. The closer you get, the more lymph nodes you're going to take as they run with those branching vessels, either the inferior mesenteric artery, the middle colic arteries, or the ileocolic arteries. So we know that by removing all those lymph nodes, clearing any cancer that has moved into the lymph nodes, then that improves survival. And the general benchmark that we use is 12. So you want to make sure you have at least 12 lymph nodes. If you don't, then that is, depending on other tumor factors and discussion in tumor board, but that is a potential indication for adjuvant chemotherapy where it might otherwise not be. And as I mentioned, in terms of where you ligate the vessel for that high vessel ligation, for the inferior mesenteric artery, if you're dealing with a sigmoid or a left-sided cancer, that's ligated at the level of the aorta. The ileocolic artery, if you're doing a right-sided cancer, is ligated at its branch off the superior mesenteric artery. And the middle colic vessels themselves are also ligated at the origin of the superior mesenteric artery. Now, the middle colic vessels are probably the ones you need to be the most careful about because the transverse colon mesentery is quite short and they can bleed and avulse very easily. And so often it doesn't seem as much of a mesenteric resection because the mesentery is actually shorter. Lastly, the last surgical principle I want to talk about in colon cancer is a total mesocolic excision. So the mesocolon, just like the mesorectum in a way, but the mesocolon has a visceral fascial plane that separates it from the retroperitoneum. And so what you want to do is you want to make sure you're excising that entire mesentery and the surrounding tissue and lymph nodes within it. So what's really required is a sharp dissection of that visceral fascial plane. And you want to dissect the visceral fascia from the parietal fascia of the retroperitoneum. That way you're not coming in and out of the mesentery. There's no potential that lymph nodes that you're leaving behind by violating that visceral fascial plane. By doing a total mesocolic excision, you are taking back to the embryologic planes to ensure that you're getting all lymph tissue where the cancer could potentially spread. So those three things combined, resection margin, high ligation, and total mesocolic excision will ensure that you have the best possible surgical resection and oncologic operation for the patient. So I want to go over a few diagrams that show exactly what that means depending on your tumor location. So for a quick, brief anatomy review, the superior mesenteric artery supplies blood flow to the jejunum, ileum, and the first 2/3 of the colon, whereas the inferior mesenteric artery supplies blood to the last 1/3 of the colon, the descending and the sigmoid colon. So the superior mesenteric artery has several branches that come off, and it's difficult, I think, at times to remember what's the order of the branches, but it's really actually quite easy if you just remember that they come off in reverse order, going from more distal on the bowel to more proximal. Meaning, yes, so the first branch, there are some pancreaticoduodenal branches that come off the superior mesenteric artery, the inferior pancreaticoduodenal. But after that, then it just goes in reverse order from distal on the bowel to more proximal. So the middle colics come off first, and then the ileocolic, and then the ileal branches and the jejunal branches. So if you just remember that it goes backwards, that's often a useful trick to know where the vessels are. So here we have a diagram. We're looking at right-sided tumors and trying to figure out what needs to be resected. So for tumors of the cecum, ascending colon, or hepatic flexure, you want to do a high ligation of the ileocolic artery. The right colic artery is sometimes present. It's not pictured here on this diagram, but that actually is has the most varying anatomy of the colic branches. But you do want to do a high ligation of that right colic if it is there. And then you also want to ligate the right branch of the middle colic. So you have to see where those middle colic branches come out. The true middle colic itself is actually quite short coming off the SMA, and it branches pretty quickly, typically in 3 branches, right, middle, and left. And you want to make sure you identify that right branch and take that as well. Next, for left-sided tumors, talking about descending colon tumors, sigmoid tumors, and rectal tumors, you need to do a high ligation of the inferior mesenteric artery right off the aorta. You want to take it flush with the aorta. The left branch of the middle colic is taken for descending colon tumors as well that are higher up, as the lymph node basin could drain there as well as the inferior mesenteric artery. Next, transverse tumors. So transverse tumors are often very tricky depending on where they are in the transverse colon, meaning proximal, mid, or distal. As you can see here, oftentimes it can be very difficult If you do an extended left colectomy to get that transverse colon to reach down to the rectum for an anastomosis, sometimes you need to do some fancier maneuvers such as a retroileal window or a Deloyer's maneuver, which are beyond the scope of this lecture, but we can talk about another time. So oftentimes, just for ease of reach, the easiest thing to do is an extended right or a subtotal colectomy with an ilio-descending anastomosis. So when you're doing that for transverse tumors, you do a ligation of the ileocolic artery, like we talked about. And you do a ligation of both the left and right branches of the middle colic artery near its origin. You do want to preserve the left colic artery, and the left colic usually is the first branch of the IMA, and it branches off in an ascending ascending direction as it comes off the IMA and runs with the IMV, and that still allows good perfusion through the marginal artery to that descending colon. And then the small intestine rotates over, is very free, as you know, and then you can do a nice side-to-side anastomosis to the descending colon. Transverse colectomies are sometimes done, usually in pretty rare situations, especially for oncologic cancers. And there have been some data that shows it has a higher leak rate, and so it's often discouraged. Lastly, talk a little bit about splenic flexure tumors. Here, again, depending on the anatomy, the length of the colon, the redundancy, you might be doing just a segmental colectomy where you go mid-transverse to basically proximal sigmoid, and you ligate the left branch of the middle colic, you ligate the left colic right as it comes off the IMA and preserve the IMA trunk. Sometimes if it's actually a proximal descending, you actually do a left colectomy, and you take the left branch of the middle colic and the IMA, and you make that transverse colon reach down with some of those advanced maneuvers, if necessary, that I mentioned. Or sometimes you do a subtotal colectomy, like we just discussed. The splenic flexure is probably the difficult decision-making in terms of what surgery to do, and often when I have patients who I have a splenic flexure tumor that I'm speaking of in the office, I describe both a subtotal colectomy and a left colectomy and tell them until I get intraoperatively, I won't know which one I'm going to do, just in terms of what I think will be easiest to perform a good oncologic operation, but also get the colon to reach back to the rectum and do a good tension-free anastomosis. Okay, now I want to talk a little bit about laparoscopic versus open surgery for colorectal cancer. There's been lots of many trials that have looked at this. And when speaking of colon cancer, the data is clear that laparoscopic surgery is no worse in terms of oncologic outcomes, disease-free survival, overall survival, etc., but does have the benefits that we know come with laparoscopy in terms of smaller incisions, less pain, shorter length of stay. So in terms of the treatment for colon cancer, primary treatment of stage 1, 2, and 3 is surgical resection. The principles we did talk about, just to highlight those again: high ligation of your vascular pedicles, minimum 12 lymph node harvest with a specimen, and at least 5 centimeter margins. And we talked about laparoscopic surgery as well as being equivalent and really preferred when a patient is a suitable candidate for surgical intervention. And lastly, I want to move into rectal cancer. For starting off by very early stage 1 rectal cancers, the treatment of choice for T1 and 0 depends on a few things. You're always safe in terms of doing a proctectomy, some kind of either low anterior resection or abdominal perineal resection, depending on the location. A radical surgery for T1 N0 cancer is not wrong, but you can avoid a major surgery like this and do a transanal excision, which often is assisted by the TAMIS or TEM platform, in select cases when there's no high-risk features. So if there's no lymphovascular invasion, if it is not poorly differentiated, or if it's not SM3, meaning the depth of invasion is less, then you can consider a transanal excision, provided your preoperative workup, as we discussed in the previous lecture with MRI, shows that it does appear to be T1 N0 mass. T2, however, you do not want to perform a transanal excision. Here you're looking to do a proctectomy without any neoadjuvant therapy, because in these patients that are T2, they can have up to a 25% lymph node positivity. So you're not performing a good operation, a good oncologic operation for these patients with a transanal excision. So a proctectomy is what would be recommended in this case. There is some data sort of beyond the scope of this lecture, but talking about transanal excision with chemotherapy and radiation therapy, which can have was shown to have about an 80% survival rate at 5 years, but that is just for patients who cannot tolerate a proctectomy. Okay, so now moving into kind of the meat and potatoes of rectal cancer surgery, and that's for locally advanced rectal cancer, so talking about T3 or T4 or node positive. For those patients, we do start with neoadjuvant chemoradiation. It's the standard of care to lower the risk of local recurrence. And typically, we give historically long course chemoradiation with 45 to 50 gray over 5 weeks. And it's given concurrently with 5-fluorouracil or oral Xeloda. And originally, typically surgery then follows 6 to 8, but more recent data, we've been pushing that out more to 8 to 12 weeks. Rest interval, or the newest thing is to add the neoadjuvant systemic chemotherapy also prior to surgery. So the concurrent chemotherapy, not to confuse you, that's given with that radiation, the 5-FU or the Xeloda, it's kind of, you can picture it as kind of just a sprinkle of chemotherapy. It's to sensitize the radiation, to make the radiation more effective to get better local shrinkage or control of this cancer. But we know for these patients, they're going to get chemotherapy postoperatively. And so for these patients, we've started adding it preoperatively in the neoadjuvant setting for what's called total neoadjuvant therapy. So they get their chemoradiation followed by chemotherapy, then surgery. And the reason that order has drawn a lot of popularity is that it's been shown to have better downstaging, which can make the surgery easier. Patients have less time with an ileostomy if you're doing a low anterior section with a diverting loop ileostomy, because they don't have to get through all their chemotherapy, and a higher completion rate of chemotherapy, because patients do better when they're not recovering from surgery and having to get chemotherapy. There's also more and more data coming out about short course radiation, not to confuse you even more, and that's being thrown into the mix as well. But in general, the thing to remember is that for T3 or T4, so stage 2, or node positive, which is stage 3, then these patients are going to get neoadjuvant therapy of some kind, which will be a combination of chemotherapy and radiation therapy. Lastly, I want to talk about total mesorectal excision, which is the additional surgical principle to talk about with rectal cancer surgery. The mesorectum is the surrounding fatty tissue around the rectum itself. And so it's the fascial envelope that we want to make sure we excise the entire mesorectum, because in the mesorectum is where all the lymph nodes that drain the rectal cancer go. And so if we don't do a good resection of this, and we don't have an intact total mesorectal excision, we know this is associated with a higher local recurrence rate. And we're doing these patients, we're not giving them the best oncologic surgery. So we want to make sure we excise this entire mesorectal envelope. We're peeling this fascia propria right off the presacral fascia, and we're taking it all the way down to where the mesorectum ends, basically at the anal rectal ring. You can see a couple pictures here of these first two, A and B, are really good, complete mesorectal excision, where you see a nice bulky mesorectum. It has what looks like a rectal, it's described as a buttocks. There aren't any defects in it. It's a nice shiny surface. Versus in C, you can see there's really no bulk to that mesorectum. It's very jagged, and you can actually see a visible defect down to the muscularis propria. Again, there's been a lot of debate recently about laparoscopic versus open, and then even more recently robotic approaches for rectal cancer. Originally, the ACOSOG Z6051 study, the initial results showed that perhaps laparoscopic was not non-inferior to open surgery, but the follow-up disease-free survival and local recurrence showed that they were equivalent, and it's generally accepted that minimally invasive approaches to rectal cancer are quite oncologically appropriate, in addition to all the additional benefits of shorter length of stay, decreased incision size, decreased pain. And you can see here on the these last few diagrams of the rectum itself. For tumors of the upper rectum that are above the peritoneal reflection, the same principles apply. So you want to get a 5 centimeter distal margin. So you don't need to do a mesorectal excision down to the pelvic floor, down to the levators for an upper rectal tumor, as long as you're getting a good distal 5 centimeter margin. However, for mid and distal rectal tumors, you do need to perform a total mesorectal excision because you're going to be getting, you probably won't be 5 centimeters before you're getting down to the end of the mesorectum itself. And so those are the main surgical principles that guide our treatment and our surgical intervention of rectal cancer. The last few things that we'll talk about in another lecture sometime are good surgical principles in terms of if you're doing an anastomosis, you want to make sure you have adequate length, a tension-free anastomosis, that it's well perfused. In the cases of left-sided and rectal cancers, your perfusion is going to be off the marginal artery, so it's good to check that in some way, whether it's visibly flashing it or some kind of perfusion test that you perform. Because the last thing you want to make sure is that you have the thing you want to make sure is that you have a well vascularized anastomosis that you're creating. There's a lot of information to cram into a quick lecture about surgical principles of colorectal cancer. I hope it makes sense. Any questions, please don't hesitate to reach out. I'll be happy to answer any questions. And as a reminder, at Cleveland Clinic, we are doing a Surgery live webcast case discussion. Happens the second and fourth Friday of each month, 6:45 to 7:15. Our next session is April 24th, and we do it every second and fourth Friday. You can check it out at this website right here. We're happy to have anybody, programs or individuals, log in and participate. And any questions, don't hesitate to reach out to me for that. Thanks so much for your attention. Really appreciate the opportunity to speak to you guys, and everybody stay safe out there.